Yeah, a very warm welcome. I'm not sure if you can see me, so I'm the person raising their hand here in the camera. It's my great pleasure to welcome Oliver Wieben, which we know for quite some time, and it's a great pleasure that you spending some time during your vacation to come over and also give a talk here. And before you start, I'd like to give a little bit introduction. Where do you come from? Originally, as we heard from your name, you have studied in Hanover, electrical engineering, and then moved to Karlsruhe to did your master's, or at that time diploma. And during that time, you had some collaboration with medicine in Wisconsin, where you started your MSc thesis and also did your PhD. And then after your PhD, you considered where you should go in the future and get a fellowship where you, as a return program, so to say, from Germany, to check if this is something which you could be interested in, and moved to Freiburg, a quite famous group in NMR, and have been there for nearly 3 years, did some studies there, but then decided to going back to America, which is bad for Germany, but good for the US. And then in medicine, Wisconsin, you did a very, I would say, typical progression from becoming assistant professor, associate, and now I think last year, 2 years ago, yeah. In 2019, you're already full professor in Wisconsin. And you worked in cardiovascular MR for a time, in image acquisition, in image reconstruction. And I think your main subject is MR flow. And what I like very much is that you trying to get the physics and having always in mind clinical applications and steering physics and reconstruction techniques towards clinical application. And so that's the title of your talk. MR flow imaging, validation, assessment of complex hemodynamics, and the power of functional challenges. And I would like to, the people in the stream, I like to say that if you want to ask questions, there is somewhere hidden. If you're scrolling down in the stream, there is a possibility to enable the chat, and then in the chat you can put in your name and also questions. And afterwards, we have a small audience here, Corona conform in the regulations, asking questions, but we have also questions from the chat. And I'm very grateful that you're here, and the floor is yours.
Well, thank you so much, Thomas, and the whole team here at the PTB for this warm welcome. It's a privilege and an honor to be here. And I am the person sitting in the front here if you're watching online, and welcome to the people in the room. I'm glad you could make some time out of your day to watch my presentation. As Tobias said, my background is cardiovascular MRI and MR angiography, and today I will focus on what kept me mostly busy over the last 20 years as hemodynamic analysis, quantitative flow imaging. And I selected some topics that I thought might be worth sharing and where there might be some potential for future collaborations or some ideas. So more specifically, today I want to give a brief introduction on what quantitative MRI, or specifically phase contrast motion encoding, is about with a focus on traditional 2D phase contrast imaging and what we call 4D flow MRI, and the term will hopefully become more familiar as we go through the talk. I will briefly talk about sources for errors, and turns out that validating flow imaging is surprisingly difficult, so I will talk about a few selected validation approaches. I want to talk about improved workflows, how we can improve the robustness of quantitative flow analysis with semi-automated tools and with artificial intelligence. And I also want to talk about application. I think Tobias already mentioned that. It is true that I really work in this space where I like to see the things that I'm working on being applied in patients, and that's a strength of the institution I'm at. There's great collaborations between the radiology department and the basic scientists, so we typically have that in mind. That also works pretty well with grant writing, typically. Couple of applications that I've chosen here with a particular focus on what I call functional challenges. So instead of just doing imaging at rest, introducing some kind of functional physiological challenge. And that includes exercise in the bore, liver and abdominal imaging with meal challenges, using actually intrinsic challenges, the respiratory pressure changes during breathing, to look at venous flow changes, and pharmacological interventions. So starting very basic here and reminding people that in MR imaging, we're acquiring data in what's called the K-space or Fourier space. That's somewhat unique, I think, that we're actually acquiring data in a transform space like that, where we literally take a 2D or 3D Fourier transform to reconstruct the images. We do that by using temporally pulsed gradient system. So we have a strong magnet, we have linear field gradients superimposed, and then we have coils. So it's very basic engineering at the end of the day, how we're influencing our acquisition. It's worth noting that the data we're reconstructing, kind of inherent to the Fourier transform, but also inherent to the underlying physical model, is represented by a magnitude and phase. So we're looking at a net magnetization vector of an ensemble of spins in a voxel, and in clinical imaging, in 95% of the cases, we are throwing away the lower image here, the phase image, and focus on the magnitude image. My talk today will focus a lot on that phase image, actually. Take another step back here and talking about traditional MR imaging, which is not quantitative. Traditional MR imaging produces images, as I'm showing some cranial examples here, T1 weighted or T2 weighted images, or flare images. There are all kind of different emphasis that can be generated by playing with those gradients and the RF excitation. So the signal is really a complex function of parameters such as proton density, most importantly, but also T1, T2, T2 star, diffusion, flow, magnetic susceptibility, chemical composition of the tissue, and then the acquisition parameters themselves. That has led to the use of MRI as mostly a qualitative imaging method. Most of clinical imaging really relies on these kind of T2-weighted images that I showed you before. However, there is really a growing trend and incentive to do truly quantitative imaging. I'm showing you an example here for fat fraction mapping. So instead of the signal being some kind of associated quantity with T1 weighting, but also depending on coil sensitivity or other parameters, we like to generate parametric maps that represent a fundamental tissue property, for example, fat fraction as a percentage. And there's a whole array of such applications. Size measurements, relaxation mapping, T1 and T2 mapping is pretty hip in some applications. Blood flow, my topic for today, concentrations of different materials. You see a couple of things listed here. So that's really a little bit of a paradigm shift here. In MRI, we don't have the MRI Hounsfield unit or things that we see in other medical imaging modalities. And it's not lost on me that obviously this is something that's dear to your heart here. I'm at the PTB where that is the focus of a lot of your work, is doing truly quantitative and robust kind of assessment. But again, my main message is MRI historically has not necessarily or has done very well, actually, despite being truly quantitative. And now there's really a good motivation to do better. And that brings me to one specific application of quantitative imaging. I would call it probably the most clinically established one, the one that was earliest brought into clinical practice. This is also documented by clinical approvals. There's reimbursement since more than 20 years for this kind of imaging. A lot of the other things that I mentioned before is on the research end of things, and there's kind of, people like to start using in the clinic, but often you don't get reimbursed. So good indicator for how established the technique really is, in my opinion. So this goes back to work from actually Professor Moran, who worked at the University of Wisconsin-Madison, but not in the medical physics department, on recognizing that you can do motion encoding with the use of bipolar gradients. And what bipolar, so these bipolar gradients are played out along one of the gradient axis in time in the direction that you want to do the motion encoding. And then depending on the speed of the spins, there's different phase accumulation due to that motion from the bipolar gradients. For static spins, the accrued phase introduced by that bipolar gradient zeroes out to a net gain of 0, versus a moving spin. If it's a constant velocity, you can show that basically phase accrual is linearly proportional to the velocity of the spins. There's higher motion encoding principles. You can do also acceleration coding with more complicated gradient waveforms or so, but really, in the majority of cases, we're interested in velocity imaging. There are some caveats. There's some unknown background phase in MR imaging, so you typically have to acquire at least 2 acquisitions, one to establish the unknown background phase, kind of shown here in this image on the right, where you see a dramatic phase drift in areas that are not affected by motion, and so to separate the desired quantitative measure of velocity from that background phase. So it makes the acquisition a little longer, but it's pretty easy to implement. Here is a typical acquisition. We do a baseline acquisition. We are doing a second acquisition with that bipolar gradient that I just mentioned, shown here in red. And then we can get quantitative maps. And if we do more sophisticated imaging, this is what we call cine imaging. So we're acquiring multiple images throughout the cardiac cycle. In reality, this is really acquired over 10 cardiac cycles or so and stitched together. So it gives you the illusion of real-time imaging, which I will cover later a little bit, but it is really not. And let's go through the steps in a little bit more detail. So I mentioned earlier that in MR you always get a magnitude and phase image. So there are corresponding magnitude images. They sometimes help to locate the anatomy a little bit better. If we just take out a single time frame of this time series, we have a quantitative map. In this case, we encoded velocity in what we call the through plane direction. So velocities in or out of the plane are either shown in black or white. Interesting, the vendors decided to implement that with different notations, so that can really mess with some of our clinicians, unfortunately. And that's where standardization comes in, but that boat might have sailed. It's hard to revert that now. That this has been in practice for a while, but you can do quantitative measurements. A typical workflow would include drawing ROIs, either manually or these days maybe with AI support, or other segmentation algorithms. You get a flow measurement, a velocity measurement or flow measurement if you integrate all the velocities over that selected area. So again, I didn't particularly point that out, but this map is a quantitative velocity map of motion perpendicular to the scan plane. And if you do the same analysis for the different images in the time series, you get a flow waveform. So this is your instantaneous flow throughout the cardiac cycle. And you can easily derive measures such as the net flow passing through here to determine, for example, cardiac output by integrating the area under the curve. So very powerful clinical measure. It's used pretty widespread, mostly in cardiac applications around the heart. I already mentioned cardiac output. I will show you an example of cardiac of regurgitation volumes, valve insufficiency. There's a whole array of clinical indications to do these measurements. So here we're imaging over the mitral valve. You see black and white flow. You also see some flow basically in the wrong direction. You would like the flow to go predominantly in a single direction, but this is a patient who has valve insufficiency. You can quantify that. You can look at the forward flow, the desired flow, and what's called the regurgitant volume. And there are clinical parameters at thresholds at what levels you do certain interventions, for example, surgical. Other applications include neurovascular work, for example, flow to the brain, and everything I've talked so far about was focused on blood imaging. You can also do that for CSF, for cerebral spinal fluid imaging, in conditions such as Chiari malformations. You can easily change the flow encoding direction from what I described so far as through plane into individual in-plane directions. And that is powerfully shown here on the right, similar example to what I showed you before, where you see flow through the valve plane, maybe more powerful with in-plane velocity encoding. You can also expand that concept and apply gradients, these bipolar gradient pairs, in 3 orthogonal directions and get 3-directional velocity encoding. So now you've encoded the whole velocity vector in a single plane. And then you get images like I'm showing you here in the cardiac application. And why stop there? Why not go to what we call 4D flow imaging? So now we're introducing the component of 3D volumetric coverage. So instead of just focusing on a single slice, we can focus on a whole organ, the whole heart, the whole brain, for example. This leads to very lengthy acquisitions, but can be done, as shown here in a slide that was provided to me from Michael Markle at the Northwestern University. Now we have to acquire a lot of data. We have to do volumetric coverage, and we have to cover 3 velocity encoding directions and the reference scan. But that provides us with a very powerful platform where we can do vascular imaging based on these 4D flow data sets, kind of a combination of the magnitude and the velocity data. We can do sophisticated 3D velocity analysis and even expand that to additional hemodynamic parameters, which I will cover in more detail in my presentation. This is also referred to as time-resolved 3D PCMR, which is probably a better term than 4D flow MRI. Is pretty ambiguous, in my opinion. But that's kind of what has stuck in the field. Key point is it's volumetric coverage. It captures the 3D nature of the velocity vector, and it does so throughout the cardiac cycle. And here are just some examples showing you the power of this 4D flow approach. It's pretty unique in that sense. There's no equivalent in ultrasound or in other imaging modalities to capture a large flow field in a similar way. Look at this very complex abdominal scan here with a lot of collateral vessels. If you, I sometimes tell people, this reminds me on you being in a big department store, you're at Karstadt, you either have a flashlight, that's your 2D imaging, where you only see a part of the picture, or you switch on all the lights and you can really get an overview of what's happening. Here's some other examples in liver flow, venous cranial flow. So just giving you an idea what can be done. So it's not just limited to imaging velocities at selected locations. You can get good glimpses of the connection between vessels and velocities, direction of flow, and you can quantify it. And you can quantify additional hemodynamic parameters. Here are a couple of examples that are of high interest in the field. Pressure gradients. You cannot calculate absolute pressures, but with Navier-Stokes equations, you can calculate pressure differences in the velocity field. That plays a role, for example, in estimating transstenotic pressure gradients without actually having to do a catheter measurement. Wall shear stress is a parameter of high interest to clinicians. This one is probably the most erroneous in MRI, the hardest to quantify. I will not talk much more about that today, but it always tickles the clinician's interest, for sure. Pulse wave velocity, kind of a measure, an estimate of a parameter related to vascular stiffness. So that's very interesting in the context, for example, of atherosclerosis. And turbulent kinetic energy. I will show you some examples of that, where you're looking at abnormalities in the flow fields. So with that, there's really a wide range of potential applications for 4D flow imaging. And it has been used predominantly in the aorta and the heart, because those are the largest vessels and allow for the most compromised spatial resolution in some ways, but also because there are a lot of important clinical implications. However, I will show you examples of liver flow imaging. There's a lot of work in cranial applications. And we've expanded recently into doing placenta and fetus imaging. So there's really a lot of target organs and vascular territories that you can approach with 4D flow MRI. And it can help in understanding physiology, so that we learn a lot about normal and abnormal flow patterns, things that nobody has looked before, for example, and after surgical repairs, predicting aneurysm rupture. There's potential for being a much earlier indicator of cardiovascular disease than when you already have a severe narrowing or stenosis of a vessel, for example. That's a decade of things happening over 20 or 30 years, and stands to argue that there will be some flow changes or stiffness changes in the vessels before that happens. People hope to do better risk assessment for the rupture of aneurysms, treatment planning, and treatment monitoring. That's where really the quantitative imaging comes in if you do long-term follow-ups. Couple of things that have happened in the last 2 decades or so that have helped to facilitate the clinical translation of 4D flow imaging. A lot of gains in hardware, particularly in gradient systems, reducing echo times and repetition times, which is really beneficial for flow imaging as well, not only for faster imaging, but also for reducing artifacts. There's a lot of work in parallel imaging, better coil technology to get better SNR, do more localized imaging, higher field strength, 3 Tesla. I put the plus in here because I obviously know that some of you here, Stefan Schmitter, for example, works in 4D flow imaging at 7 Tesla. So a lot of potential there. Some of the hardware gains, especially if it comes to gradients, I see to start to taper off. I think that there was a hot phase, but we're establishing more steady state because we're reaching physiological limits. before safety concerns become important. And I will also say that some of the hardware improvements, those very short TETRs, very strong gradients, have introduced eddy currents that we have more neglected before, that have basically decreased some of the reproducibility of our measurements, so that special attention is needed to some of these advances as well. I don't want to go into too much detail here on this slide, but I want to certainly bring home the point that there has been a lot of methodology improvements to improve either spatial resolution or temporal resolution or decrease scan time. A couple of them are mentioned here, predominantly parallel imaging, I would say, KT acceleration, and now more recently compressed sensing, constrained type of reconstructions, and work on non-Cartesian trajectories. And I will talk a little bit about radial imaging in a second. But it really had the effect that we dramatically reduced scan time. This is just a selection of a few applications. This could be continued. There are even faster acquisition schemes now. But this all started in '96 with the 30-minute scan that is clinically not feasible. And is brought down now to 10 minutes and less. And this is specifically here, this table, for acquisitions that require breathing compensation. So only typically you can, like as an estimate, you throw away half of the data basically. If this would be a brain scan, you could cut the scan time in half because there's no need for compensation for our breathing motion. So something that we've pursued at the University of Wisconsin pretty intensely in general, but specifically for flow imaging, is radial sampling schemes, and that's something that's very familiar to some people in the room, including Tobias, who started working on this similar time when he was still working at Philips. So contrary to standard MR acquisitions that start at what we call a Cartesian or rectangular sampling grid, this sampling occurs in a radial direction. So each individual readout that we can steer through our gradients basically traverses through our Fourier space along a line that, that intersects with the center or the origin of the Fourier space. And then we align these projections in certain angles. There are various schemes how to properly align them to cover the whole 3D sampling space properly. We sometimes call it the Kush ball because it reminds us on the toy Kush ball. And our implementation with the 3D reassembly, we call it vastly undersampled isotropic projection reconstructions, VIPER. So you will hear this term a few more times in the presentation. This is really based on work on Chuck Mistretta, my PhD mentor in Madison. So this can easily be extended to flow encoding by using the same bipolar gradient schemes that I mentioned before, again, played in all three axes, plus a reference scan, so that has not changed. There's still 4 acquisitions, but it turns out that we can purposefully undersample those acquisitions and achieve high spatial resolution with a compromise of some streak artifacts that can be often ignored or tolerated in those high contrast applications such as flow imaging. So you see here in the movie on the lower left, I'll play this again, there's high contrast, very high signal in the vessels, so streak artifacts are not even really noticeable here. Large volumetric coverage, good capture of small vessels in about 7 minutes. And those are cardiac gated scans, as you can see here in the velocity fields shown in the carotid artery. Quick summary, because that's not the main focus of my talk, but how I think about radial phase contrast MRI, the good, the bad, and the ugly. There are obvious benefits for accelerated imaging, not only for undersampling, but also because it's more incoherent artifacts introduced when you combine it with compressed sensing. A lot of people have switched to radial imaging because of that reason. Very high spatial resolution, as I've shown. It has some favorable motion artifacts. I will show that a little bit later. It also enables what we call ultra-short TE, or probably more accurately, short TE imaging to reduce displacement and intravoxel dephasing. It's also very well suited for retrospective gating, both for cardiac and respiratory gating. And I will also show an example of that. There are some drawbacks. The reconstruction is much more computationally intense. It involves gridding. It gets even more complicated with parallel imaging than it does in standard Fourier acquisitions. There's also sensitivity to artifacts that are more tolerated in Cartesian imaging, which is actually kind of interesting historical note, MRI imaging started as radial imaging because that was the spatial encoding that people knew at the time from CT. It switched to Cartesian imaging because it was more robust to artifacts, and now some groups like ours are revisiting that paradigm. So trajectory errors is a big thing that can really ruin your images if you don't take well care of that. Off-resonance effects are more pronounced, and displacement artifacts can be more complicated because you have a changing readout direction. I will go over this slide rather quickly, but I want to mention that there are quite a few sources of errors that can introduce problems with the accuracy and the precision of phase contrast MRI. A lot of them are very well understood and can be taken care of, fully automated, but some of them have bothered us for a long time. For example, the background phase correction is kind of a notorious problem that we see resurfacing again and again. So that makes it important to consider validation studies. And some very basic benchmark studies can be pretty powerful. Here's an example from a multi-center, multi-vendor study where basically every site built a very simple static phantom. This is just a block of agar into investigating that background phase error. And you see it was very substantial. And if you do the math, you can see that these errors are taken at regions of interest. So this basic phantom is supposed to mimic the dimensions of the chest and then areas of interest for cardiac analysis. And if you, even though these errors are somewhat small, if you integrate them over space and time, they can really become large enough to interfere with diagnostically important thresholds. It's kind of interesting here to see. This gives you a glimpse too how different vendors have implemented different schemes in their reconstructions to compensate for some of these errors. I think I know which vendor is which. This is GE, Philips, and Siemens, basically, but I'm not taking sides here. Just take note that, that some are doing better than others. And some, to be more fair, maybe some rely more on post-processing software to take care of it than others who try to fix it already at the reconstruction stage. That might be a more accurate representation. If we're talking about phantom experiments, one common way to do flow validation is with flow pumps and fluids running through the bore. There are all kinds of complications with that. It's a long setup. It's not always that reproducible, but it's certainly an important part. Here's a design that I like a lot. And actually, Stefan Schmitter in the room here from the PTB has been involved in this study. This is a pretty elegant phantom. I think it's agar, if I'm not mistaken, or something similar. And it's a rotating phantom, so that way you have a large velocity distribution, both in X and Y, with all kinds of components, with radial distance from the center of the rotation spot. So it's much less messy, and it generates a much larger array of velocities that are clearly defined, and it's self-calibrated by using some optical feedback here to track the actual spinning motion. This is something that I think could really be a much bigger thing in our field and could be distributed or could become QA at institutions, in my opinion. As you know, probably there are NIST phantoms, or maybe the PTB has some MRI phantoms, I don't know, but there certainly are phantoms that are used for QA in hospital settings. Here I'm giving you an example of another validation approach where we're looking not at the velocity fields, but at secondary parameters, specifically at pressure mapping. So here's our implementation using Navier-Stokes equations. Basically, I'm showing an example on a stenosis phantom where the steps involved require vessel segmentation and then solving a discrete system of equations that are well understood. This is really basically re-implemented from others from 2000 here, from Tiska et al., who did that with multi-slice 2D imaging. And with that, you can see here time-resolved pressure gradients kind of when a pulsatile flow pump is used. And in this case, we validated that with pressure wires, with MR-compatible pressure wires. And we did something similar in a swine study to do an in vivo validation. That's something important to note, that validation in vitro in a phantom does not always translate one-to-one into in vivo settings. There's a lot of motion involved, other uncertainties that can corrupt your data. So if you know you're doing well in a phantom, that does not necessarily guarantee you that you're doing well in vivo acquisitions. So in this case, we did not have MR-compatible pressure-wise. We did pressure measurements with DSA guidance in a swine model. So this is the renal artery with a cable tire stenosis. And then you use these very thin catheters that are used in clinical practice to establish transstenotic pressure gradients. The actual pressure sensors are sitting a little back on the catheters. And then we compared our 4D flow measurements with the in vivo measurements taken in the DSA lab side by side. These acquisitions were an hour apart. Those were 19 stenosis over a large range of pressure gradients. So what I like about this is that, clinically speaking, 4D velocity fields are impressive. They're pretty images. But translating that into a number, something you can put in a report and something that surgical decisions are made on, is a different ballgame. And that makes it much easier for clinicians to work with it. So in this case, we have all the velocity information. We condense it down to one clinically meaningful and clinically already established parameter. And here the allure is that we can do that non-invasively. We don't have to do an arterial puncture to bring a catheter into the renal artery. We also wanted to do this work in humans, but at that time, clinical practice had changed, and they started to treat patients not with stents anymore, which when we started the study would have done. So at that point, these type of pressure measurements were frequently conducted. These days, patients are mostly treated conservatively with statins because the clinical outcome has to be shown similarly. So kind of as a note, if you work in this field, sometimes clinical practice might play some tricks on your study plans. This was all lined up. We had grant funding, we had our IRB approval and everything, but couldn't follow through, basically. One other thing I wanted to mention where I think some of the advances in optical imaging and 3D printing can really help with validations work in 4D flow imaging. So this is work on the shoulders of one of our faculty members, Alejandro Roldan, who is a mechanical engineer, fluidics expert who knows a lot about 3D printing and particle imaging velocimetry, so laser-based optical systems. So we have a workflow where we, in this case, create a model. Most often that's a vascular model. Here we're doing actually a ventricular model out of silicon. So you do a negative that you print, you cure silicon in the model, you wash it out, and then you have this model which you can't really see, but that's by design. You want to have it optically matched, basically to the fluid that is pumping through here. So you don't have any refractory issues for your PIV system. So you can appreciate some pulsatility, probably not as strong as the heart itself, but introducing some motion resembling what happens during cardiac contractions, just based on the pressure changes from the pulsatile pump. And here are some images from the PIV setup. Here you get an idea of this particle imaging tracking. This is a setup with 3 cameras. I'm showing you a single slice that can be then calculated into velocity vectors. And then you have a chance to compare velocity measurements on a voxel by voxel basis with something, I still wouldn't call it the absolute gold standard, but it comes pretty close to that, much more than anything else I can think of. And you can look at local differences. For example, we know with flow imaging, slow flow versus fast flow regions are more or less accurate depending on the velocity setting, how strong you place that bipolar gradient. So that's something you can basically compare because PIV is not sensitive to that. All right. Now I'm switching gears a little bit and showing you some applications of flow imaging and some additional hemodynamic parameters. So we do a lot of work in Alzheimer's research where we do cranial flow imaging. And in that scenario, we are interested in a lot of vessel segments. This is about 13 vessel segments around the circle of Willis. This would take a long time if you do that with consecutive 2D imaging. If you do it with 4D flow imaging, you do one acquisition and you can send the subject home, and then you do all the analysis retrospectively. And in this context, we were interested not only in flow itself, in velocities and flow, but also in what we call the pulsatility index. So for that, we're looking at the flow waveform, and we're calculating the parameter pulsatility index as a combined measure of the maximum, the minimum flow, and over, like, normalized by the mean flow. And that is a descriptor of distal vascular resistance and vascular compliance. There's also a component of reflective waves, but I'm leaving that out here for the second. We've learned that this pulsatility changes in patients with Alzheimer compared to healthy patients being on the bottom, and those are patients mild cognitively impaired. They have a high chance of developing Alzheimer, but they're in a pre-Alzheimer stage. So the stiffness increases with a higher degree of Alzheimer. And we've done that in a cohort of 300 subjects, where you see how the flow increases. So from left to right, I'm going from Alzheimer to mildly cognitive impaired, to normal older, and to middle age. Age is known to be a factor in vascular stiffening as well. So, and interestingly here, actually the ones that have a 0 are the ones that are not statistically significant, because otherwise there would be too many statistically significant pairs. So I think the trend is very telling here. Across many vessels around the circle of Willis, we have a decrease in flow with basically age and with and severity of Alzheimer. Contrary, the pulsatility index increases with degree of disease in a similar statistical significance. So higher pulsatility, higher stiffness of the vessels. To add to that, none of the more traditional peripheral metrics of cardiovascular health, the ASCVD risk score, pulse pressure, mean arterial pressure, they don't show any differences. So there are changes in the brain that are not happening in the rest of the body. There are a lot of discussions about the heart and the brain, and people are starting to connect those. I think there's some, so it's something we're pursuing on a larger scale. I will show some slides on that in a second, but it's also something where I see there could be some interesting collaborations here with Ingolf Sack, who's looking at vascular changes with MR elastography. Our current workflow, as I mentioned, includes 13 vascular segments. We're gearing up to do an analysis in over 2,000 of these studies. We've been doing those scans since more than 10 years. Thought this might be of interest, but we kind of did a breakdown in our database to understand what's all behind our data. So we see, if you would prospectively design a study, it wouldn't necessarily shake out that way. We have a preferred gender participation of females. That's partially because it's more prevalent Alzheimer's in females than in males, but it's also because of a recruitment basis. We are not doing as well as we would love to in terms of ethnic diversity, but you see there were changes through the protocol over 10 years. The scanners changed, the coils changed, so how do you combine those data? So if you do these kind of larger scale studies, there are always some issues that you don't do with the smaller pilot studies or so that we typically focus on. And also, there's no single PhD student who wants to draw 13 ROIs in 2,000 subjects. So you really have to, which is of course a time issue, but also in terms of reproducibility, automating things becomes much more important in those scenarios. So we've made some efforts along this way. This is from a collaboration with Umeå, a university in northern Sweden that is using our 4D flow technique since years as well. And they've had a long-standing interest in cardiac pulsatility and flow imaging. So one of our students visited Umeå. They started to work on a tool that Umeå had already developed. There were some additional implementations. This is again a student from Sweden who started atlas-based labeling to take another ambiguity out of the processing chain or automate it. And we've done some additional updates here too at the UW, making it interactive and more automated, doing flow analysis along the whole path of the vessels, color coding them, and entering those data into databases. So I think that's an important thing to consider for flow imaging. There are some commercial products now available that are approved by authorities, but they are much more simplistic than what I'm showing here. They're more focused on flow, maybe center lines or so. And that, of course, opens the door to AI imaging, which I'm getting to next here. This is in a study in a context where we're looking for kinetic energy analysis. So where basically the measure of kinetic energy is a simple summation of the velocity squared in the area of interest. That could be in a vessel, or in this case here, it's actually in the left and right ventricle. It's well understood, has been shown to be altered both in heart failure and diastolic dysfunction, for example, but it involves the necessary step to segment the ventricles pretty well. And the image quality we have is not always that great to do a good segmentation of the LV and the RV. Here's kind of a worst case scenario, so some of our initial workflows were based on just average positions of the LV and the RV, which is non-ideal. It was still clinically significant, interestingly, but we would like to do much better. So in typical cardiac scans, we also do what's called a cardiac function scan, where we cover the whole volume of the heart, shown here just as a single slice, but much better image quality. And that allows to do very accurate segmentation. As a matter of fact, that is the gold standard to assess volume sizes, end systolic, diastolic volumes, ejection fraction, et cetera. If you want to do this kind of segmentation for 4D flow, it's a lot of images to segment, because you have to do this for all the cardiac phases, for all the slices, and if you do it for the LV and the RV, as we did in our study, that's a lot of segmentation to do. Turns out it's such a common clinical problem. There are excellent solutions for that. Here's an example from a deep learning algorithm, a study conducted in the UK on the biobank. There are 4,000 data sets annotated by clinicians. This is work we can't and don't want to reproduce. But basically, the idea was using those tools for our data sets, using I have the workflow here, using the structural CMR to do the segmentation, do an image registration with the 4D flow data, and use the segmentations from the structural data set. One additional complication of that, though, is that the data that were trained in the UK biobank had a different scan protocol than we had used historically at the UW, so there were some extra steps needed to compensate for that. And this all is under the premise that we can bring down really the processing time from over an hour for a case to a single minute. So we used the biobank, we used fine-tuning with our own data, and then testing on a rather small data set, admittingly, but those were the data we had with 4D flow and cardiac function. And I'm showing that here, I think, in essence, I'm not saying that we did the greatest job of machine learning. There are other groups who have probably more experience and can do this better, but this concept of transfer learning, I think, is very powerful and should be used more in applications like that. So just to complete the set of slides, here are some examples of the manual segmentation results with the deep learning network as it was not fine-tuned. So there were some error modes, and with the fine-tuning, basically retraining it with some of our own data really helped with the accuracy of the algorithm. And with that, the inter-observer variability agreed pretty well, shown here between the left and the right ventricle. Those numbers compared reasonably favorable with the manual segmentation versus the deep learning algorithm. Okay, all right. There's no way I get to my slides. So I do this very quick here to give you some highlights, and if people are interested in following up with me, I showed my email on the first slide. I'm very happy to discuss. It's the first time I'm giving this talk, so I'm obviously way off. I apologize for that. So there's more space for AI, for example, automated plane placement. Here's an example for flow in the greater vessels, in the vena cava, in the aorta, where we've made some initial steps on automating that. But I really want to cover a few of these functional challenges quickly. So MRI exercise is really a compelling challenge that is also established in clinical practice, but it's rarely conducted. It's really hard to exercise somebody safely in the magnet, and it's really hard to image during exercise. So a couple of examples you see here were designed to exercise somebody outside the magnet, and then go quickly in an image at a time where you're probably already in recovery. So we have a product from a company in Austria called ErgoSpect. It's built on pressurized system that's MR compatible, and it has feedback loops, so you can consistently track the actual workload conducted. It it's capable of very high workloads of 400 watts. That's probably the maximum exercise capacity of most subjects. And we've used it for 4D flow studies. That's something you could never do with exercising first and then jumping in the scanner. And I've published some work on that, some pilot studies, and also studies in actual patients. I will go very quickly through that. The image quality deteriorates to some degree, but it's still very usable data. Where we did, again, kinetic energy analysis, which was more prone to errors than the flow fields, because it's not so surprising, you square velocities. What's also compelling is convert that to actual real-time imaging. Instead of these 10-minute acquisitions during exercise, tracking changes actually in real time with flow. This is with a true real-time engine with a system called HeartVista that was developed initially on the GE platform, but is available on the Siemens platform. It's a very compelling system that I'm happy to talk to others about if you're interested to learn more about it, both in sequence design and in the real-time interface. We were not with that system, the actual temporal resolution, we saw some room for improvement, so we started to do some work with our own implementation of a radial sequence and local low-ranked reconstructions, and also more traditional reconstructions. So this is ongoing work. We're trying to achieve temporal resolution in the order of like 20 milliseconds or so that we can track in real time with this very high heart rates. If you exercise, you might double your heart rate. The meal challenge is another functional challenge if you're looking at the hepatic system. So instead of exercising your heart, you're fasting somebody, you feed them a controlled meal, and that should trigger a substantial increase in blood flow to the gut. That's when you feel tired after your meal, when some of the flow is diverted. And it turns out that this is something that has been done prior to our work in 4D flow with ultrasounders. So, but there are substantial flow changes, showing you here differences between healthy controls, where the flow goes up by 140%, versus patients with impaired hepatic flow, where that is a much more stunted response. Why is that important? Why is it just physiologic interest? No, there are some clinical implications. There's something called mesenteric ischemia, where people get really sick after a meal because they have stenosis in the blood supply to the vessels, to the gut. It's very hard to clinically diagnose. So we think 4D flow can really play a role in that. And we're currently received funding for a grant to predict variceal bleedings. So here's a patient with a variceal gastroesophageal varices. So those are extending into the esophagus and they can rupture. This is a dramatic situation where people wake up at night bleeding out of their mouth, and there's emergency surgery needed. There's a relatively high rate of people who will not survive this incidence. We're doing very poorly clinically to predict. So this is something that happens to people who have severe portal hypertension, which is a growing disease in our population. We're doing very poorly in predicting who are people at risk for these ruptures. The best thing we do right now is literally putting an endoscope in the esophagus and see how far they've developed. And people, after 2 or 3 times, they get tired of doing this kind of screening. So this could be a non-invasive way to do that. Okay, and I'm finishing this. There's also inherent physiological changes that can be used as a functional challenge. I'm talking specifically about the changes from pressure in the chest that influence venous flow. So we started to work on double-gated sequences that are gated both in the cardiac cycle and in the respiratory cycle to elucidate those kind of changes between inspiration and expiration. There are different ways how you can then break down the respiratory waveform, but the key point is you can do that with radial sampling very nicely and retrospectively. You don't have to decide it beforehand. And this has been expanded by our group on 5D flow imaging in the chest. The work I showed before was literally for venous reflux from the brain. And there's some recent really nice work from the Northwestern group and the group in Lausanne, taking that to another level with more sophisticated reconstructions and self-gating. And that's something that we're working on together now in the context of a large multi-center study, the MESA study, where we're doing this kind of challenge in people with pulmonary hypertension. And I just leave this completely out here because I'm running out of time and go to my summary slides. I hope in my presentation today I showed you some background on flow-sensitive MR imaging, 2D phase contrast as a very established clinical tool, 4D flow as something that's coming into more widespread use, both for angiogram imaging, for velocity field analysis, but also additional hemodynamic parameters. Validation, I didn't cover all the aspects of validation, but I think I gave you a glimpse that it's challenging but necessary and a lot of room of improvement. It's much more exciting and sexy to do the next pilot study in patients than really being thorough and validating these parameters. And I really think there's a lot of untapped potential with functional challenges. And with that, I thank you for your attention.
Yeah, thank you very much, Oliver. It's a fantastic overview. We're seeing there's much things you can share. And I highly appreciate that you stress the importance of quantification, to stress the effects of physical or the machine, which imperfections which can make changes on the measurements, and mentioned accuracy and precision, which is, I think, something which is really in the heart of the PTB. I just have to check if there are questions around yet. Still, you people in the stream, you can put it into the chat window. For that one, you have to scroll down into at the end of the page, and there is a dedicated chat tool where you put in your questions. And maybe I can start, and then looking here into this room here. And you mentioned as typical impacts like SNR.
Yes.
If I have done my study on 4D flow with Daniel Giese, then we found out with 4D flow, we are not that much signal-to-noise limited, because at a certain end, we can accelerate by a factor of 10, and then it is more given by the reconstruction algorithms, which introduce the artifacts, but we have been not signal-to-noise limited because we get all the data, 7-dimensional, as you mentioned, so we have so much data which we are using. So what is your feeling? Is this something we can do at 1.5? Is it something where we need 3 Tesla? Do we need even higher field strengths for 4D flow, or is this something which even we can go for lower field?
Yeah, it's an observation that I would echo from our work. I started this work with 2D phase contrast imaging, and where we did phantom experiments and limited the number of projection angles we would acquire. The flow measurement is surprisingly accurate even at super high undersampling factors. At some point it becomes a question, can you even see the vessel in your image? But the quantitative velocity measurement is often still surprisingly accurate. I'm delighted to hear that you had similar experience. There is, of course, the VNR issue, where if we target the velocity well to the expected velocity, we're doing well. But if we're in low velocity areas, our error grows pretty substantially. That's something where high field strength can really help, in my opinion, to do that. If we have a flow region where most of our velocity of interest are in a homogeneous region, it's not an issue. But often we have applications where we actually have lower and faster velocity, especially like wall shear stress I mentioned earlier. That's where you cover that. So there's a lot of potential. And then the high resolution imaging, I think the cerebrovascular imaging is where 7T can really play a role. I know Sebastian has worked on that. He could probably comment better on that. There are a lot of issues with 7T images where out of a sudden your B0 field might B1 field changes with breathing and things. Yeah, Sebastian, do you want to chime in?
Okay. Well, I had a similar question actually, because with 7T you can basically, you get, let's say in the brain, you get 3 to 4 times higher SNR, which directly translates into vessel to noise ratio, velocity to noise ratio. And so my question is rather, and well, it's a comment and a question, would you rather invest this SNR in a better velocity to noise ratio or rather into a higher resolution? Because my feeling is, well, you get a resolution, let's say you increase by, I don't know, like 30, 40% or something, you can get smaller voxel sizes, which is of course nice for wall shear stress and so on. But isn't it maybe even better to invest it into the velocity to noise ratios? People like you also showed doing dual wank or multi-wank, and you get it for free basically then. I mean, what's your feeling?
I think it really depends on the application. It's hard to do a generic answer. If you think of something like an aneurysm, you want both. You want the highest spatial resolution possible, and you want good coverage of low and fast velocities to do wall shear calculations or so, or pressure mapping pretty well in the aneurysm. There are other applications I can think of where spatial resolution might not be the most crucial factor. If you're thinking of carotid artery imaging or so, I think you can relax a little bit on the spatial resolution. But now we are facing these high velocity jets or so, where it's really hard to find a velocity that works well. So that's where I would probably invest in a dual wank acquisition or multi-wank acquisition.
Okay, Ariane.
Yeah, thank you for this very nice overview over all this like very broad range of topics. I was really interested in the Alzheimer work you presented. First of all, congratulations on the amount of people that you measured. I know that's a lot of work. When I think of dementia and velocity encoded measurements, I would jump to vascular dementia. Did you do that as well? And did you see any differences between the Alzheimer and the vascular dementia if you did that? And secondly, what other types of biomarkers did you acquire on this cohort?
Okay, so you said you were particularly interested in vascular imaging. You mean arterial spin labeling, like perfusion type of?
Vascular dementia.
Oh, vascular dementia. Okay, all right, thank you. Yes. That is nothing we have specifically looked at. I mean, there's the generic idea of small vessel disease, right? The SVD, where I think some of these patients might fall into. It's not always clear, especially when I talked about the mildly cognitive impaired patient. At that point, it's not clear whether they will really have Alzheimer's or if this is more vascular dementia. So these cohorts are very closely monitored. It's one of the jewels at our institution. It's called the Alzheimer's Disease Research Center. So those subjects are recruited, coming back on a yearly basis. They do cognitive tests. There's blood tests. There's cerebral spinal fluid tabs to look at the tau markers. There is a pretty extensive imaging protocol, and depending on the cohort, some of the sequences are acquired or not, because some focus on other parameters, but arterial spin labeling is commonly in the white matter lesion are tracked, and the center is doing an excellent job of bringing these people back. They write them birthday cards and annual cards just to keep them in touch, because you don't want somebody to drop out after 5 years or something like that, right? The value in this database is really, you know, in 10 years when these MCI patients maybe reach Alzheimer's or not, can we go back to the data and see what were the most telling indicators back at the day. Yeah, did that answer your question?
Yeah, I would be interested in, basically the question was aiming at if you do see a difference between the vascular dementia and the Alzheimer's disease, but if you didn't specifically focus on that, then...
Yes. Your assessment is correct. But it is something, you know, this is a space that is getting a lot of attention right now. I think when we started that, the pulsatility work, it was a one-of-a-kind work in the MRI space, but now the glymphatic system is on everybody's mind. People are trying to track motion more closely in the brain and trying to relate now what happens in the capillaries, venous motion, stiffness of the tissue. So I think it's a very interesting space with a lot of potential. And in the US, I don't know how it is, I assume it's the same in Germany, this is heavily funded research because it's such a burden on society financially that the NIH is very ready to, we have funding lines north of 40%, which are unheard in any other area of research.
Just looking, it's just, okay, there's one thing from the chat, please.
Okay, we have the first question from the chat comes from Bernhard Kraft from Charité. And first of all, he would like to thank you for the nice talk. And then he says, I saw something about the hypocapnia study in the abstract. I might have missed it, but how large are the flow variations in those kind of maneuvers?
So that's an excellent question. I was overambitious, I think, in my abstract. I realized I have too many slides last night and threw that out. So we indeed have worked with hypoxia and hypercapnia challenges, mostly in cranial imaging, actually, looking at autoregulation of blood flow to the brain. And then the amount of changes depends also on how aggressive you are with these challenges. Some of them can become uncomfortable if you push them too far. And they are in the order of, they're small, maybe 5 to 10%. I'm happy to send you some of our reference. This is work we've published, so I can share that with you. But it's a setup where some subjects are not very comfortable. They wear a mask, and especially in a head scan, when you have in a head coil, it gets very tight. There's graduate students then outside who control the concentrations of the air you're breathing. Our MR techs usually get half a heart attack when these studies happen. So those are some unique studies, I would say. But yeah, we've been doing them, and we've used them in subjects with metabolic syndrome to look at actually at brain flow too again, and we're expanding it partially to some cardiovascular imaging.
Okay, one more question here from this audience. Christoph?
You showed some examples of the Viper trajectory, and also you mentioned that this is quite challenging in terms of reconstruction. Just a more general question, how do you do it in your institution? Do you implement everything on the scanner for your clinical studies, or do you do some offline reconstructions? How do you handle that?
Yeah, excellent question. We've early on established a workflow of doing everything offline because it wasn't possible to implement it on a time scale that it can be done on the scanner without interfering with the clinical scans. It would bog down the system, basically. These days, we could do more online, but we really like the offline workflow. It's not clinically intuitive because it takes some time for the images to be sent back. However, these 4D flow scans, they are never analyzed on the spot anyway. And it gives us the power to run, do studies like here where we compare different respiratory gating schemes on the very same data set, for example. So we have a workflow where we automatically pull these data onto our Linux cluster of the scanner. As soon as they are done, they're reconstructed and sent back to the magnet. That way, again, we felt there was the least interference with the clinical scan. Sometimes, and I don't know if that's different on the Siemens or Philips system from GE, but sometimes the system slows down or goes almost to a halt until the images are reconstructed and back. Nobody likes that if they're sitting, twiddling their thumbs for 5 minutes or so. So yeah, it's all offline for us. I'm happy to share more details about the technical implementation of the actual algorithms.
There's maybe one more from the chat.
Yes, so Gerd Lindner would like to know, in your area, did you perform the combining CFD simulations for prediction purposes?
CFD simulations?
Right.
Yeah, so I have not. I'm not an expert in CFD, and I'm not claiming I'm being one. I think there's a lot of potential. I think when I started in this field, we almost used 4D flow to validate CFD. As strange as that sounds, I think people came in with the idea of thinking CFD is the gold standard, but there have been well-published CFD challenges where top groups in the world have very contradictory results. So I think we're not there that CFD is a gold standard. So I really think there's an opportunity to merge these two and to have the benefits from both. And there is some initial work in that space, not from our group, but where people start doing that. And you can even bring AI into that and learning some of the, we know, as an example, for a 4D flow scan, we kind of have a little bit of a map of how much we trust the data in which region, going back to the VNR discussion. In the slow flow regions, there's probably a larger error than in the high flow region that are more closely to the bank. That's interesting information to tell a CFD system. Here are some measurements. Here's how much confidence we have where, and now find us a solution with your constraints on top of that to match what is the most likely true flow field from there. So I think there's great potential.
Yeah, perfect. Thank you very much again. And the good news is, one of the reasons why you're here today is that we are discussing a research day, your sabbatical next year, which will hopefully start in next September.
That's right.
And then we will have much more time with all the different groups in Berlin, which are also remotely in here, and going in much more detail. So thank you very much for coming, and thank you very much for the presentation.
Yeah, thank you very much for your attention. Thank you for the excellent questions. It was a pleasure to be here.